In December and January, we conducted several focus groups with community members, hospital staff, board members, and physicians. Earlier this evening, we had the pleasure of reporting back to the focus group participants on what we heard in the focus groups and discussing next steps to make improvements. This information, as I mentioned earlier, will be captured in a report which will be available to public. One of the things we heard in the focus groups was the need for information and support for families and patients that are experiencing this end-of-life journey. Tonight, we are fortunate to have a special guest speaker with us who is an expert on end-of-life care, and in particular, in the role of caregivers. He has written 50 books, including Caring for Loved Ones at Home and Family Hospice Care. Right now, he was just telling me most of the questions that came up earlier during our conversations, you can actually find some answers in his book.
Self-promotion, I'm sorry.
His books on caregiving have reached an audience of more than 1 million patients, family caregivers, professionals, and volunteers across Canada. He is a passionate public speaker and adult educator, focusing on patients and their families. On a personal note, Mr. Van Bommel has cared for his parents and grandfather at home in the last chapters of their lives. I will now call upon Harry van Bommel to begin his presentation.
Thank you so much. Thank you. Could all of you stand up with me, please? This comes free with tonight's program. We're going to do a little bit of Tai Chi because you've been sitting and sort of not moving a whole lot for some of you for 3 hours. So I just want you to loosen up a little bit. This releases tension in your shoulders, also makes you look silly, and so that's always good to start an evening not too serious. Out from your heart, in towards your stomach, very slowly. If your shoulders rise, you're trying too hard. Again, it's to relax your shoulders and your neck muscles. Some of you are going backwards, and that's perfectly okay, because it's just a circle. And the last one, your left hand, for some of you the other left hand, facing your face, palm in. Your right hand pulls you 45 degrees, and then you switch. Right hand to your face, and you turn around, and you just go nice and slow. For any of you who take trains, planes, or buses, and you want a particular seat, and someone's sitting there, start Tai Chi, and not only that seat, but several on either side. We'll free up for you. Okay, you can have a seat, thank you. I'm going to speak to you about some just stories of what excellent hospice care looks like. As you heard from my introduction, I took care of both of my parents and grandfather at home until they died, but I've also taken care of other people since then. And it's not always end of life. Sometimes it's lovely at the beginning of life. Our daughter was born at home as well. It was wonderful. There's handout bookmarks for you on the way out, so you don't have to take notes. There's basically the 4 pillars that you've heard about tonight already. There's the physical needs, emotional needs, some people call it psychosocial needs, spiritual, and information. I just want to tell you some stories of how I've seen that done exceptionally well. The first one is a story about Mr. G. Mr. G was a patient in a palliative care unit in London, Ontario, and he had a tumor that covered most of his neck and part of his face. And he was receiving excellent physical, emotional, spiritual support from his family, from the staff and volunteers of the hospice unit there. But he wanted to die. He said, you know, as much as people are helping me, I'm pain-free and alert, I don't have bad symptoms. What I can't control, however, is the look on people's faces when they come into my room. And the look is always one of horror, because I look horrible. And so although I've got all the best things happening for me, the best thing that you as a palliative care team could do for me is to help me to die. And his wife agreed with him. How many of you have ever been an 8-year-old granddaughter? Come on now. Most of you, okay? How many of you have an 8-year-old grandson? Just to, be fair. Okay, this guy had an 8-year-old granddaughter, and she wanted to see Grandpa in the hospital. And the palliative care team at the time decided that would be too difficult for her to experience. And so her parents agreed. How many of you, when you were 8-year-old granddaughters, really, really wanted something? And your parents didn't want to give it to you. This little girl really, really wanted to see her grandpa. And so she bugged and bugged and bugged, with big smiles, with tantrums, whatever it would take, until finally the parents said, well, let's see if we can get the team to help you get ready to go visit Grandpa. So she went into a special room at the hospital where some of the staff were, and she tolerated all these lovely adults trying to prepare her to go see her Grandpa. And as you can imagine, an 8-year-old sort of looking at the ceiling and going, yeah, finally they said, okay, he's down the hall, room on the left, you can go and go see your grandpa. And so she ran down the hall as only an 8-year-old would do. She pushed open the door, ran to her grandpa, and said, I love you, Grandpa, don't go. And in those 2 sentences, she understood hospice palliative care better than all the well-trained people, all of her parents and her aunts and uncles who all had agreed that she wouldn't be ready to do this. She saw Grandpa, and he and everyone else saw a cancer patient with tumor. Now, if any of you have ever watched Star Trek and those kind of shows, there's some really ugly characters with all that makeup on, but underneath some of them end up being lovable Klingons. And so that's the same with people who have disfiguring faces and bodies. The person they are inside hasn't changed. How we see them changes. And so she saw her grandpa as whole. And there is no greater gift in hospice palliative care than seeing whoever you are there for as whole. Perfect as they are, complete as they are, not requiring lots of extra stuff in order for them to feel who they are. So that's part of the emotional aspect of taking care. So this man obviously wanted to live longer for his granddaughter. And I think that was an excellent example. When I took care of my mother, she had horrible pain. And I was taught how to give round-the-clock injections. Not something I learned in history class at university, which is where I had been just soon before that. And what I found out afterwards, after both my parents and grandfather died, is that no one has to suffer unbearable pain and symptoms. And I wanted to introduce in the audience someone who taught me some of this stuff, Dr. Gillian Gilchrist is second row from the back, just wave there. She's the founding medical director at the Oshawa General Palliative Care program before it was called Lakeridge. And she taught me and many, many other people from across the country, mostly doctors, but sometimes people like me, about effective pain and symptom management. Pain is not enough. Sometimes itchiness and nausea can be worse than pain. And so that we know how to do now. And I asked a nurse once who does pain and symptom management, how long would it take a physician or a nurse to learn pretty general pain and symptom management control for about 80 to 90% of patients? And she said about a weekend. So this is not rocket science. This has been proven for decades, and we just don't use it enough. In the Hospice Victoria, they give families, when a patient is living at home, they give them a tackle box, and in the tackle box are lots of different drugs. And when if there's a breakthrough pain or some nausea or a real itchiness at 3 o'clock in the morning, rather than rushing to emergency, they call up this 24/7 line, give the situation, they say, well, in the tackle box, third little tray on the top right, there's a blue pill, give 1 now, or 2 now, and 1 in 4 hours, or something like that. So that the family doesn't have to rush every time something new happens that they haven't prepared for. The spiritual aspects of care. One of my favorite teachers in hospice palliative care was named Dr. Dorothy Lay. She's one of the founders of Canadian Palliative Care, along with Gillian and a few others. And she had a saying that the heart of hospice, which is the title of her book, the heart of hospice is spirituality. And however you and the person you are supporting defines that. And we all define that differently. And so it's very important that we understand the difference between imposing what we think is right versus what other people think are right. I once gave a talk to volunteer chaplains at a hospital. About half of them were Christian and about half of them were Muslim. And during the break, one of the Christian ladies came up to me and said, "You know what?" And I said, "What?" "They're nice, aren't they?" I said, "Who?" "Those Muslim people over there." I said, yes, they are very nice. And they actually had a sort of a competition to see who could bake the nicest cookies. And I participated fully in the competition to see who did, and they were equally good. But she said, you know what? I said, no, what? They're not going to go to heaven. And that's when I taught her, and I spoke to the director of chaplaincy of this hospital. There are people who are wonderful at what they do from a spiritual perspective, but some can only deal with people of the same faith. I had a friend in her 80s who I used to call Gran. She's the grandmother of my best friend from high school. I used to visit her every week to play Scrabble. She whooped me real bad. And she was a born-again Christian and I was not. And she promised not to die until she converted me. That did not work. She died, unfortunately, anyway. But the point was, I couldn't fulfill all of her spiritual needs, but I could fulfill some. So at the end of every visit, she would say a prayer, and we would say it together. I would bow, and she would say the words. It was wonderful. But my real role as a friend, or as a volunteer, or as a doctor, or nurse, or social worker, was to make sure that she was also tied in with members of her church who would visit more often with me asking them than they did without me asking. So spiritual care really is about meeting that person's needs as opposed to trying to convince them that your view is correct. Information. So we've looked at pain, emotions, spirituality. Information is what I concentrate most on. When I was taking care of my father, he was the last of the three to die, and I said to him, I really should know how to do this better by now. And he said, no, you're doing he felt very, very bad that I had gone through this 3 times now in 4 years. And someone in their 20s really doesn't know squat about this stuff. And so I promised him after he died that I would start to research and write to help other families. And so one of the stories he wanted to make sure that people heard was when he and I were going to give my mother her first bed bath at home. Now, we knew nothing about how to give bed baths because in hospitals at the time, anytime something like that happened, family was asked to leave the room. And then when you take them home, you're supposed to learn from osmosis what happened in the room when the door was closed. And so I said to my dad, I said, so how do we do this? And he said, well, it can't be that hard. I used to bathe you when you were a baby. That's the first clue this wasn't going to go well. Because when I was a baby, I was this big. My mother was somewhat bigger. So when a baby, you basically wash them head to toe and then dry them head to toe. It's very quick, it's easy, and they're nice and dry. My mother froze to death. This was January on the 15th floor of an apartment building with leaky windows. And those of you who are laughing are ones who have done bed baths before, because other people think, so yeah, what's the problem? In a bed bath, if you wash someone from head to toe completely, then they get goosebumps the size of little molehills that you could ride dinky toys over because they're so cold. The proper technique, we had a visiting nurse come to visit us the next day. She said, so how was everything yesterday? And so we were quite proud that we'd helped my mom with her first bed bath. So how did you do that? We explained it to her and her face turned red. She hid her laughter, though. That was very nice. And she didn't call us idiots. She says, well, that's certainly one way to do that. And my mother was awake, so she could have told us we were doing it wrong, but she didn't want to make 2 guys feel bad, right? Because we were useless and she didn't want to add to that. So she said, well, why don't you watch me give a bed bath? And so we watched her take my mother's arm from outside the blanket and wash it and dry it and put it back under the blanket. And then the other arm, and then the leg. And she gave my mother the cloths for her to do some of her own washing. Never occurred to us we could ask her to wash herself. Never occurred to us. And so information is vital, and it's no rocket science. When you see it once, you think, oh yeah, I should have known that. I don't know if you've ever seen a draw sheet. A draw sheet is a folded linen, and instead of going the length of the bed, it goes across the middle of the bed. I thought that was for incontinence. That's the only thing I'd ever seen it used for, but in fact, it's to help someone move in bed. My mother had various forms of cancer, one of which was bone. And so she would slide down in her bed, and we would, as gently as 2 loving a husband and son could do, try to pull her back up into bed under her arms. It was very painful. We had no idea that a draw sheet, one on either side of the bed, we could just gently lift her up and she wouldn't feel pain at all. Information is priceless. And when we don't have it, we look stupid, but we feel worse. Those are the memories of her last weeks that still haunt me, that shouldn't. And they shouldn't haunt anyone's of the people that come to visit your center. I want to talk briefly about a phrase that is used that I would like to discourage any of you from using. I call it a deadly phrase or a phrase that is harmful. and that phrase is quality of life. Quality of life used to be a measurement comparing what happened between populations of people. So was it better to live in a city or a town? Was it better to be educated or uneducated? Was it better to be rich or poor? Some fairly obvious answers here, but people got a lot of research dollars for this. So it was comparing populations of people. That you can do. You cannot measure someone's individual quality of life. Any of you who have gone through extreme grief will know that your quality of life for those first 2 weeks is horrible. That's not a good time to ask someone if they have good quality of life. There's a survey of elderly people, 70 years and older, and they were asked if you had a choice between having some pain and living longer or no pain and living a shorter time, which would you pick? And the worried well, that's what Dr. Elizabeth Latimer used to call people who are healthy, who try to predict what people who are not healthy think. They thought the majority of people say, no, they'd rather be pain-free and live a slightly shorter life. 70% of people who are 70 years old and facing that decision said, no, I think I'd rather have a little pain so I could go to one more Christmas, one more anniversary party, one more birth of a grandchild. So we are very bad at measuring individual quality of life. So I would encourage you, not only those who are working in the field, but also those who are promoting hospice palliative care in your communities, not to use that phrase, because it can be deadly. There are people who believe, there was a doctor, a neonatologist in the Netherlands, which is where I'm from originally, who believed neonatologists take care of premature babies. He believed that if a baby boy was born with a crooked penis, that they should not be fed. And they should be allowed a natural death, because what kind of life could they have? That was someone else imposing a quality of life on a child barely hours old. So we have to be very, very careful about those terms. I wanted to end with a couple of quick examples of excellence that I've seen by people in the field. One is a physician at St. Michael's Hospital in Toronto, who whenever he has a patient come see him, he's in the palliative care unit there, whenever a patient came to see him, at the end of their discussion, he would help them on with their overcoat or suit coat. That took an extra 30 seconds, but the daughter who was in the room with them remembers that decades later. The small thing, someone was describing to me at Providence Center, where sometimes women, volunteers or staff will go in and help women with some nail polish. You may think that that's superficial, but we spend bazillions of dollars telling women how to look pretty, but when they find out they're dying, all of a sudden, oh, you look fine. You haven't washed your hair in 2 weeks, oh, it's okay. You look good, Ma, you look good, Grandma. Well, they don't feel good. And so we can't change 60, 70, 80 years of history of that person being told a certain way, and then when they're ill at the end of life saying that doesn't matter anymore. So Providenceville does that really well. It's something to be applauded. There are doctors who will fluff pillows. There are nurses who advise doctors on pain and symptom management. I spoke to a chaplain at Casey House, Toronto's AIDS hospice, when it was first opening up, and his greatest frustration as a chaplain was that none of the residents asked him anything spiritual. They asked him about the rules of church. Can so-and-so come to the funeral? Can I be buried there? How many people are allowed to visit? He said the spiritual conversations were being held with the residents and house cleaning staff, or the people who bring them food 3 times a day. And so he found out that part of his job was to actually train housekeeping and dietary people how to have a spiritual conversation with some of the residents, because he couldn't do it himself. And so there are no rules. There's no sort of job description that says only doctors do this, only nurses do this, only social workers do that. It really is whatever the patient needs and whoever can give it best, whatever the tie is. Sometimes the tie will be closest with a nurse, sometimes with a social worker, sometimes with a chaplain, and sometimes with a volunteer. And none of them are better than the other as the first option. Whomever connects with the patient first is the one that you want to have it happen. I'm going to leave you with one other example of, before I show you some of these books that you can get for free. There was a nurse in Montreal, and during the December 6th shooting of women at the college there many years ago, merci beaucoup, there was a lot of news, and it was on all day long when it was first happening. And this nurse was walking by a room, and she saw a woman crying, one of her patients, palliative patients, who was crying. And so she took some time and went to sit beside her and said, "This is very sad, isn't it?" And she said, yeah, it's very sad. But why are you crying? It wasn't a judgment, it was a question. One of the greatest gifts you have, all of you, is to ask a question from curiosity as opposed to from judgment. So she said, "So why are you crying?" And she said, "Well, I had a daughter who died. And no one in this unit had heard from her husband, the remaining daughter, anyone, that she had had a daughter who had died. And this daughter had died a few years before from cancer, and her mother had strongly encouraged her. She said, I forced her to go through experimental drugs and stuff, and it just devastated her. And I just can't get over that." This woman had intractable pain. No medications could control it, and they were trying everything. But once she was able to talk about her daughter's death and her guilt about forcing her to go through a painful death when it wasn't necessary, and bringing in her husband and other daughter and starting to have a conversation with them, then her pain became controllable. Because then she was talking not just the physical pain, but emotional, spiritual pain can cause physical pain. I asked my father, I was the one who told him that he was going to die, and I had fluked onto a way of helping people give bad news. I went to him and I said, "Dad, I've spoken to your doctors, and they give me some news. Would you like to hear what I said?" Now, had it been good news, I would have just told him, of course, and he would have been fine. He knew it was bad news, so he had 3 choices. And when I asked him the question, I remained quiet for 2 minutes. And normally if we had longer, I'd ask you to be quiet for 2 minutes with your eyes closed and raise your hand when you think 2 minutes are over. Most of you would raise them by 30 seconds. 2 minutes is a very long time. During that time, he had 3 choices. He said, he could say, "Yes, son, I want to know what you found out." "No, son, I don't know what want to know, you can tell your sister." Or, "Yes, I want to know, but not today." He chose the latter, and then he rehearsed in his head what it is he actually wanted me to tell him. So after 2 minutes, he said, "Yes, I'd like to know, but not today. Ask me again tomorrow." For the first time in his medical history, he had control over information. Every other time someone came into the room when they thought it was best to give whatever they did, stay for however long they could, and leave. The next day he said, "Am I going to be at your wedding in June?" This was in November. I said, "I don't think so." That's all he wanted to know. Next day the question was, "Am I going to make it for Christmas?" I said, "I don't think so." And so he had 2 of the major things that were worrying him off his list. He knew he wasn't going to make either one of them. And so over the next couple of days, he asked more and more questions. I gave him more and more answers, what to expect, was it going to be painful, all those sorts of things. But he had control. And so physical, emotional, spiritual are very, very important. But the information piece, having control over what you get when you're ready to receive it, is vital. And so in fulfilling my promise to my father, I've written 3 books of the about 20 that I have on family caregiving. These are the 3 that are most helpful. And on the bookmark, you'll find on one side of it the website carelibrary.com. And all 3 of these, plus the other 17, are available for free on that website. You can read them, print off whatever you think would be helpful. One is for families just to take care of someone physically at home, the nursing. Figuring out how to give a bed bath without having to have a visiting home nurse teach you after you've really done it poorly. So this is for anybody, and not just for people who are dying. Family hospice care looks at physical, emotional, spiritual information needs. It looks at powers of attorney, it looks at living wills, it looks at pain and symptom management, what are the most common ways of doing that. It looks at the World Health Organization ladder of how to manage pain and how to manage symptoms, not just with medication, but with other things as well. So it looks at many of the things that we in our focus groups presented as things that we wanted to know. So for the hospital, or for Rouge Valley, both hospitals, they can find whatever they think patients need and their families take it rather than having to reinvent the wheel, or for patients and their families to go directly to the website and just read whatever chapter is helpful. This also looks at how to create support circles around people who don't have extended family. Because most of us think we can't live at home until we die because we only have one family member and they can't do all the work. I've helped people set up support circles so that there's enough support around so people can live at home until they die. And lastly is the gift of care. This is mostly for healthcare professionals, but also for family caregivers, and it looks at the attitude. A lot of the things that we looked at around the focus groups as well is about education and training. But the primary thing that I've learned from Louise LeBlanc, who's an expert in volunteer training, is that it's less the training and it's much more the recruitment. If you start with someone who gets a lot of this stuff instinctively, then the rest is just skills development and works really easy. If it doesn't come instinctively to you, it's very hard to learn. And you will either try to force your opinions onto people, or you will completely just acquiesce to everything the person says, even when it's not a good idea. So this looks at the attitude of that caring is a gift. And the last thing I will offer to you is, from that book, is there's a concept that we all grew up with, which is, it is better to give than to receive. And what that means is, as long as I'm the one giving, I'm feeling good. How many of you are good at offering help to other people? Yeah, that's what you're here, otherwise you wouldn't be. How many of you are good at asking for or accepting help? A few less hands, yeah. And that comes, I think, from that belief that it is better to give than to receive. If that is really true, then half the people in that equation are always on the losing end. And we can't let that happen. It's why elderly people would rather eat their cat food than ask a neighbor to add a few things in their grocery cart for them. It's why people will not tell their children that they're suffering pain because they don't want to be a burden to their family. I have forewarned both of my children that I expect to be highly burdensome and to get used to the idea early on because I am not going to go quietly into that good night. And so that concept of this, it is better to give than to receive, I would like all of you to carefully think about how dangerous that is for the half the world that relates to. There are no awards for the person who received care best. There are only volunteer awards for people who give care. That's not a fair equation. We need to have both.